Hello, my dear curious and studious students of surgery. Myself, Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome, dear students. In my surgery lecture number 33, that is the diseases of the rectum and diseases of the anal canal. In this lecture, we will learn the rectum and the anal canal anatomy, prolapse of the rectum, Thiers operation, excision of the prolapse mucosa, complete prolapse, evaluant sponge, that is the wrap operation, rectopexy operation, rectal sling operation, perineal approach, that is the Delorme's operation, Lahanant's operation, resection operation, that is the anterior resection of the rectum, perineal Recto-Sigmoidectomy, operation on the pelvic floor and perineum. All these points will cover in this lecture. Now start with the rectum and the anal canal anatomy. First we will see the anatomy of the rectum. It is continuous above with the sigmoid colon and below with the anal canal. Peritoneum is reflected from the anterior wall of the rectum to the bladder formine, recto-vesical pouch of the peritoneum in the male and recto-uterine pouch in the female. And the arterial supply of the rectum are from arteries of like superior, middle and inferior rectal arteries and middle sacral arteries. Dilatation and tortuosity of superior rectal vein are called internal haemorrhoids. This possibility occurs due to absence of valves in the vein, internal pressure from fecal impaction, external pressure from a loaded pelvic colon, gravid uterus, fibroid, etc. Straining at stool, especially during constipation, as the vein passes through the rectal muscles and develop the haemorrhoids. Here is a good picture of rectum and anal canal anatomy. You can watch. This is the second picture, clearly shown all the structures like sigmoid colon, dented line, surgical anal canal, anal verge, the internal sphincter, the external sphincter. All these structures are clearly seen in this image. Now the nerve supply derived from the sympathetic and parasympathetic systems. Now the anatomy of the anal canal. It is about 1.5 inches long in adult. In front, relation with the perineal body, laterally ischiorectal foci, behind anococcygeal ligament which separates it from the tip of the coccyx, and whole length, surrounded by the sphincter muscles which in turn keeps it closed. Each column contains the terminal radical of the superior rectal artery and veins. The left lateral, that is the 3 o'clock, and the right anterior, that is the 7 o'clock, and the right posterior, that is the 11 o'clock positions are the most common sites for the primary internal hemorrhoids, that is the piles. The imaginary line along which is the anal walls are situated is popularly known as the pectinate line, that is also called as the dented line, the important landmarks for the surgeons. The epithelium above this line is supplied by sensory fibers from autonomic nervous system and therefore insensitive to painful stimuli such as the cutting and cauterization of epithelium. Below this line is innervated by spinal nerves and has somatic sensation. Anal canal musculature compounded by the internal sphincter, the longitudinal muscles and the sphincter ani externus. Nerve supply of the anal canal are upper part developed from the hindgut, supplied sympathetic and parasympathetic nerve supply. Lower part developed from protoderm, inferior rectal nerve and somatic nerve. The spaces on the lateral side of the canal, anal canal and the rectum there are three spaces. One is the perineal space, contains external hemorrhoids plexus, and the ischiorectal space, sites of the abscess formation and formation of the horseshoe fistula development, pelvically rectal space, that is resulting in a high fistula. Now the next point of this lecture is prolapse of the rectum. This can be differentiated into one partial prolapse and second is the complete prolapse. First we will see the partial prolapse. When only the mucosa and submucosa of the rectum come out through the anus, it is called partial prolapse. The length of such prolapse is never more than 3.75 cm. If this prolapse mass is palpated with the fingers inside the anus and the thumb on the outside of the mass, means outside of the anus, it will be evident that it is composed of two layers of the mucous membrane and submucosa in between. Now here is a animated picture on your screen. There is a partial thickness of the mucosal prolapse and full thickness of the prolapse. You can clearly see. Here is the partial prolapse and complete prolapse is seen. This is the diagram of normal rectum and prolapse rectum is seen in the lateral view of this image. Etiopathogenesis of the partial prolapse are: this condition occurs children below the 3 years and elderly people. In children, faulty bowel habits, straining such as attack of diarrhea or whooping cough, loss of weight and diminution of pararectal fat. In adults, some loss of tone of anal sphincter, third degree hemorrhoids. In female, torn perineum, excessive straining due to urethral obstruction from enlarged prostate and excessive coughing. Complicate operations for fistula in ano, fissure in ano if excessive stretching of anal sphincter. Now the treatment. First, conservative treatment. Digital repositioning. The mother is taught how to replace the protruded bowel, avoiding straining of stools, control of diarrhea. And second line of treatment in conservative treatment of the partial prolapse of the rectum is submucous injection. 5% phenol in almond oil under J should be injected. This is tried in children only after digital repositioning fails for 6 weeks trial. This submucous injections treatment may also be tried in adults. 10 ml of such solution may be injected in one setting. Will lead to fibrosis and the mucous membrane becomes fixed to the muscular coat and is drawn in. Now operative treatment for the partial prolapse of the rectum are: first is the Thier's operation and second is the excision of the prolapse mucosa. First is the Thier's operation. This operation means the stitch is taken around the anus in the external sphincters with silver or stainless steel wire. Wire should be removed after 3 months. And second is the excision of the prolapse mucosa. The base of the prolapse is ligated by the Goodsall's ligature, transfixed twice and the ligature is then tightened. Dear student, here is the image. You can see that is the image of the Thier's operation. The 20 gauge needle is used and the stitch is taken around the anus and fixed there. This is the step by step of Thier's operation is showing on this image, and last image is showing the complete of the Thier's operation. This is the image of the excision of the prolapse mucosa. You can see step by step. This is the another image, animated image of submucous excision of the partial prolapse of the rectum. Now the complete prolapse, that is called as a procedentia. In this condition, the rectum comes out through the anus and the protrusion consists of all the layers of the rectal wall. It is descending sliding hernia. It is always more than 3.75 cm in the length and usually about 10 cm in length. If palpated between a finger and the thumb, double thickness of the entire wall of the rectum can be palpated. It must be remembered that a complete prolapse usually contains a pouch of peritoneum anteriorly between its wall. When the prolapse is a very large one, this peritoneal cavity contains even coils of the small intestine. So always remember this. Men and women's ratio are 1:5. Means women are more affected for this procedentia, complete prolapse of the rectum, than men. Etiology factors: bowel habit associated with a long history of difficulty with defecation, laxity of the anal sphincters, most obvious abnormality found apart from the prolapse itself. Sphincteric response to voluntary contraction is also poor. Now here is a good image of the complete procedentia. This is the prolapse of the rectum, complete prolapse procedentia. Now the next etiology factor are sliding hernia. May be peritoneal pouch on the anterior aspect of the prolapse, lack of the rectal fixation, muscles of the pelvic floor are weak, the rectum is more mobile. It is also not fixed posteriorly to the sacrum. Rectal intersusception, the rectum folds on itself and passes through the pelvic diaphragm and ultimately comes out of anus. The cause of such intersusception is not known. Disordered functions of the pelvic floor muscles may have marked laxity of the whole pelvic floor and anal sphincters mechanism. A few patients, even after rectopexy, shows persistence of the incontinence. Now the treatment. There are various operations designed by various surgeons for complete prolapse of rectum. The more commonly practiced operations are mentioned below. First is the fixation operation, that is the Evalon sponge wrap operation by Wells. Wells described this operation in 1959 through the abdominal approach. The rectum is fully mobilized to the pelvic floor. A rectangular sheet of the Evalon sponge polyvinyl alcohol is then sutured to the presacral fascia and the peritoneum of the sacrum, periosteum of the sacrum. The mobilized rectum is drawn up to make it taut. The Evalon sheet is wrapped over it and sutured on the periosteum of the sacrum. The anterior surface of the rectum is left uncovered to prevent constrictions of the lumen. Evalon sponge will initiate fibrosis and fix the rectum in the place. Dear student, this is the text picture on your screen, shows Evalon sponge wrap over the rectum. A sheet of the Evalon sponge is sutured to the presacral fascia of the sacrum and then wrapped over the rectum and suture. The anterior part of the rectum is not covered, evidence of the narrowing of the lumen. This is the Avallon sponge. Now the second operation is the rectopexy, that is the Lockhart-Mummery operation. The incision and preliminary steps are similar to the previous operation. A curved incision about 2 inches in length is made midway between the anus and tip of the coccyx. External sphincter muscles and the anococcygeal ligaments are cut. Fascia and walled air is transversely incised. The rectum is stripped off from the anterior surface of the sacrum up to the third sacral vertebra. The resulting cavity is packed with long strips of gauze of the polyvinyl alcohol sponge and suture. The effect of this sponge is to provoke vigorous fibrous reaction which will anchor the rectum against the sacrum. This is the good picture which showing the rectum is sutured with the presacral area of the sacrum. This is the image of the rectopexy showing before and after the operation. The posterior part of the rectum is sutured with the presacral area and coccyx in dotted. Now the third operation for the rectal prolapse is the rectal sling operation, introduced by the Repstein in 1965 by abdominal approach. Rectum mobilized down to the tip of the coccyx. The lateral peritoneum folds are open and the rectum is freed from the sacrum. The rectum is pulled up, taut. A 5 cm band of Teflon is placed around the rectum and sutured and presacral fascia and periosteum of below the sacrum 5 cm below the promontory of the sacrum. Then the next operation is the perineal approach, that is the Delorme's operation. The collapsed rectum is pulled down as far as possible. A series of the chromic catgut sutures are used to imbricate the underlying muscles. When these are tight, the rectal muscles is pulled up toward the anal canal. The anal canal mucous membrane is now sutured to the rectal mucosa, which remains at the tip of the prolapse. So the prolapse is reduced and the ring of the muscle surrounds the anal canal, which narrows its orifice. This prevents recurrence. Then the Lehant's operation, whole of the rectum and lower sigmoid colon are mobilized. This is now held up and stitched with the rectus sheath. Here is the sling operation, image of the sling operation you can see. Then the second type of the operation in the rectal prolapse are the resection operation. First is the anterior resection of the rectum. Technique. The technique is essentially similar to the anterior resection of the rectum for carcinoma. Only difference is that the resection should be close to the rectum to prevent injury to the nerve supply of the bladder and to prevent impotence in the males. The proximal line of resection should be at the convenient point at the recto-sigmoid junction or in the sigmoid colon so that the redundancy is removed. The anastomosis must be done without intention. And second resection operation is the perineal recto-sigmoidectomy. This is a technique in which the redundant recto-sigmoid colon is excised through the prolapse itself. The patient is placed in Trendelenburg position or prone jackknife operation. A circular incision is made through the outer layer of the prolapse, 2 cm prolapse to the dentate line, up to the 2 cm proximal to the dentate line. The pelvic colon should be pulled down as far as possible until it becomes taut from above. The sigmoid colon is completely divided below the anus in such a way that there is a greater length posteriorly. The two cut ends of the bowel, the anal cut externally and pelvic colon internally, are now sutured by a series of interrupted sutures. The suture stump is now pushed into the anal canal and a rubber tube is inserted. This is the perineal recto-sigmoidectomy, picture of the perineal recto-sigmoidectomy. You can see here is a sigmoidectomy seen on your screen. Now the third resection operation in the rectal prolapse are operation on the pelvic floor and perineum. This operation is Gollinger's modification of Rose-Graham operation. With this operation, the rectum is mobilized and pulled up. The levator and muscles are approximated anterior to the rectum. The peritoneal pouches are obliterated. Also used Avallon rectopexy as the primary treatment and posterior anal repair to the improve pelvic floor and sphincter functions. These are mainly varying degrees of the incontinence due to the anal sphincter dysfunction. The simplest method for trying to improve sphincter function is by exercising the pelvic floor muscles and by applying the Faradic stimulation. Here is a anatomical picture for the resection operations on the pelvic floor and the peritoneum. There is the levator ani muscles, the gluteus muscles maximus, the coccyx, the anus, all are seen anatomically. This is the lateral view of the pelvic floor where the operation is to be done, resection operation for the rectal prolapse. Dear students, this is the theoretically I explain you, but there are very good videos on the YouTube. You can refer it for the fixation operation like the equivalent sponge wrap operation, that is also called Wells, explained by the Wells, rectopexy, Lockhart memory operations and rectal sling operation, perineal approach, Delomez operation, Lehant's operation, resection operation like anterior resection of the rectum, perineal recto-sigmoidectomy and operation on the pelvic floor. All these videos are available on the YouTube. You can refer it to clear your concepts. And here is the end of our surgery lecture number 33, that is the disease of the rectum and the disease of the anal canal. Thank you, students.